Well, good afternoon, everybody. It is a Thursday afternoon at around almost 2. Not quite. Hey, listen, I appreciate the Zoom meeting last night. Once again, just want to let you know because I know I'm going to hear something. The 8th, June 8th, notebook is due. Okay. I'm going to call you or get in touch with you somehow. I need to get in touch with you on the 8th. Okay. If you get it done, the notebook, before the 8th, let me know and we can get that out of the way. Okay. I'll write your name down, all that kind of good stuff. Don't forget your 10 points extra credit. Yeah. Okay. 10 points extra. Okay. By sending a letter of thank you to the doctors, the nurses, the entire staff at Desert Valley, and just let them know that you're thankful for them and thankful for their commitment. Okay. And if you send it to Desert, it's capital A Schaefer, SCHAFER, at, hold on for a sec. What? primehealthcare.com. Okay. And April will get it. She'll let me know and you'll get your 10. Okay. The notebook. Okay. So the extra credit's got to be out of the way too on the 8th. So just tell me that you did it. I'll have a list anyways, and we'll give you that extra credit. Okay. Um, your notebook. I'm going to say, show me your notes. And you're going to go, Mr. White, these are my notes. Okay. And I'm going to go, that's good. And then you're going to show me your textbook with all the strips filled out on the 8th. Okay. You're going to show me your 3-page type report, and I'll probably have you read it to me. I'd like to hear what you wrote. Okay. And then that's going to be that. And then on the 10th, June 10th, this year, okay, is the final exam. 100 questions. Okay, you've got 24 hours from the time I post it to turn it back in. So don't, I know people come up with, not that you guys would, but all kinds of stuff like, hey, Mr. White, my turtle has leukemia. I'm going, all right, that's cool. I hope the hard shell makes it through this, but you know, okay, so there's not going to be any way that I can help you if you don't do the final exam. Okay. All right, now I am here. I am ready for your calls anytime. Just let them roll. Big wheels keep on rolling. Is that how it goes? Never mind. Okay, so just make sure that you let me know what your questions are. Excuse me. All right, now I'm going to kind of move over and try to introduce to you a general idea of what's going to be on the final. Same thing I did for the mentor. And I kind of gave you a hint in the Zoom meeting last night. I mean, a big hint, big breadcrumbs there. All right. So, everything that we've taught thus far. Okay. But I'm going to try to get a little bit more specific here. So here we go. Final exam. Know your rates. I mean, if I were to say to you, what's the rate of the essay node, you would say, hey, what? 60 to 100 per minute. That's cool. Above 100, it's stack. Below 60, it's braid. Okay. If I were to say to you, junctional, right? 40 to 60. Don't forget though, junctional, if it can, 40 to 60 is its normal inherent rate, but it can go above 60 up to 100, and that's called accelerated junctional. If I say, what's the rate of an IVR? 20 to 40, right? But it can go above 40. This is ventricular, idioventricular rhythm, right? 20 to 40. It can go above 40 up to 100, and that's accelerated idioventricular rhythm. Idioventricular rhythm, don't let it confuse you, it's called IVR. All right, I'm looking. You can also have something that comes on suddenly. And the word is paroxysmal. Paroxysmal, which means sudden. Okay? If you get a paroxysm, any pacemaker can become irritated and start firing, right? From a stimulant, from stress, whatever. Okay, start firing, right? And that would be considered under the bounds of paroxysmal. Yeah? And usually that rate is between 150 to 250. Paroxysmal, sudden. Okay. I'm sitting here taking notes, talking to you. No, it's not my heart started. That's sudden. That's paroxysmal. 150 to 250. Flutter is 250 to 350. Fib, and this is hypothetical, is 350 to 450. All right. I'm looking. I think, you know, as you're working through skill stat and so forth, okay, when you look at something and you guess that it's right, try to explain why you're saying it's right. I mean, what is it that stands out about that particular rhythm that makes it what you just said it was, okay, like a first degree AB block. So if I give you a word picture of a rhythm, you should be able to tell me what I'm talking about. Right? Why deep tall QRSs? Some high, some low. Some high, some low. Maybe the rate's 300. You're going to go, that sounds familiar. Yeah, it's a party streamer. Remember that? Torsades de pointes, which means, literal translation, twisting of points. All right? If I show you a junctional rhythm, right? What makes it junctional? You see P waves? You go, no. Well, why? Because the P waves, if you could see them, and you do sometimes, are inverted. Prior to the QRS, after the QRS, buried within the QRS. So you would go, well, looks like a junctional rhythm. All right? It's going to be a little bit slow, but I want to try to get through this to try to help you out. If we mention the most common dysrhythmia, well, probably one of the most common ones is atrial fib. Okay? What if I were to give you that in a word picture? What if I were to say multiple ectopic atrial foci all discharging at once, irregular ventricular rhythm? You go, yes, atrial fib, Mr. White. Cool. Anytime you hit wide deep tall QRSs, you're probably ventricular something. Okay. Anytime you hit inverted P waves, prior to the QRS, after the QRS, buried within the QRS, and a short PR interval, shortened, right, less than 0.12, you're probably dealing with something junctional. You know, what if you went up to a monitor and you just saw, you know, P waves, long lines between them? And do you go back to the doctor and go, you know, sir, let me tell you, the rhythm is regular. What do you got? You got ventricular standstill, right? Yeah. I want you to know the difference between a sinus arrest and a sinus block. Now, as far as I'm concerned, in reality, guys, you can call this a sinus pause, okay? Because if we say sinus pause, we're talking both about sinus arrest, sinus block. And they're both treated exactly the same way. Remember, sometimes you're going to get premature beats. How do we know? Because when you look at a strip, you're looking at it from what? Left to right, right? You're taking your calipers, you're going P to P, marching them out, not pulling them in or out, going down the line, right? Take the same calipers, not pulling them in and out. You go R to R, right? Everything marches out. But then all of a sudden you get a beat between there. There's calipers, you get a beat right here, say. Yeah? Okay? It's premature. Like a premature baby comes early, the premature beat comes early. So you've got to say, is it premature atrial? It's got a P wave, and the P wave looks different in size, shape, and direction than the other P's. And it's probably a what? A PAC. Pac-Man. No. Okay, a premature atrial contraction. Remember the word overdrive suppression. Overdrive suppression means you got a pacemaker somewhere up here, yeah? And it tells all the other pacemakers, keep quiet, I'm in charge. And the way that it does that is because it can drive the heart the fastest. Whoever can drive the heart the fastest is in charge. And normally it's what? The SA node, right? And so it tells atrial, junctional, and ventricular ectopic foci, keep quiet, I'm talking. There was a commercial as I was growing up. It was on insurance. Not if they don't have enough of them today, Geico and all the rest of them out there. But watch. I think it was, it was on money more, but it said, when E.F. Hutman speaks, everybody else listens. The same way with a pacemaker that's dominant. This pacemaker that's dominant can drive faster than the rest of them, and it overdrive suppresses the rest of the pacemakers. Atrial, junctional, ventricular. Now, what if I had said you had an SVT? What would I be talking about? A supraventricular tachycardia. What does the word supra mean? It means above. Above. So supraventricular tachycardia could be what? Could be junctional tach, or it could be atrial tach. Now, the reason they say that is because maybe you don't know. Remember, tach is fast, right? Okay, especially if it's paroxysmal, you know. All right, so watch this one. And remember, I told you that sometimes the P waves, if the rhythm is so fast, can join the T wave and become one big bump. So if there's one big bump, is it atrial or is it junctional? It's kind of hard to, so you just call it an SVT, meaning, I don't know, it could be junctional or it could be atrial. So I'm just going to call it a supraventricular tachycardia. All righty, let's see what we got here. Okay, those P waves, long lines between them, what would you call it? I have no idea. Actually, I do, but... All right, the word hypertrophy looks like hypertrophy. I mean, it looks like it. It says hypertrophy. It's pronounced hypertra, T-R-A-F-E-E. Not really, but that's how we kind of pronounce it. It means enlargement. Congestive heart failure, hypertension. A stenotic or narrowed valve can cause hypertrophy of a chamber of the heart. I want you to know your cells, your myocytes, your mechanical cells in the heart, right? Myo, muscle, site, cell, yeah. Know the states. Like if I said, okay, a myocyte is polarized. I want to know what's on the interior, what's on the surface. If I say it depolarizes, what's going on now with electrolytes? If I say it repolarizes, what's happening? I may say, what is a polarized myocyte doing? You should know. Want you to know your limb leads. Want you to know your chest leads. Want you to know where they go. That'd be nice, yeah. Want you to know the various waves, what they represent. Okay. I say, what's a P wave or represent, or what's the QRS represent, or what's the T wave represent, or even the U wave that you don't always see, but what does it represent? You usually don't see U's unless the rhythm is really slow. I want you to be able to define certain things, like if I said, what's a significant Q, Q like Quebec, versus an insignificant Q? How would I know I have something significant? How would I know I have something insignificant? And what does it represent? So know your limb leads, know your chest leads, know where they go. If we use the word vaso, some people call it vaso. Remember, it means vessel. So if I say to you something vasoconstricts, or something vaso, V-A-S-O, dilates, yeah? You know where the mediastinum is. Where is that puppy? Okay. I want you to know the triad. Ischemia, injury, infarct. Know those three. Know what they mean. Know how you kind of spot those on the EKG. Okay, on the EKG, on a 12 lead, geez, what? Out of all the 12 leads, what strip goes on longer than all those 12 leads? I mean, what's the longest strip that you have to look at in there? Is it a lead 1, a lead 2? Is it B1? You know, what is it? I want you to know heart sounds. S1, S2. What's going on, okay, during those heart sounds? What valves are open, what valves are closed? What are the name of the valves? If I say to you semilunar valves, name two. If I say to you atrioventricular valves, you should be able to tell me which ones and what side of the heart they're on. No intervals. Know your normal PR, your QRS duration, your QT. Okay, know those. Know about blood flow. I forgot to tell you. This is good. Years ago, we had interviews for the director of the paramedic program. Years and years ago. And what they do is they gather, you know, maybe like different professors from around the campus. And one of them happened to be Mrs. Bartz, who taught anatomy at the time. And they had another professor that taught physiology out there, and the nursing directors and so forth. And so, you know, they're all out there in the audience, and, you know, they bring the person up front, and they said, okay, play like we're your students. Yeah? We're your students now. They're saying to this person that's interviewing, what we'd like you to do is trace blood flow through the heart. Sounds reasonable, doesn't it? So the person gets up there, and this is what they say. Yes, before I trace blood flow through the heart, what I'd like to mention to you, which is very important, is where the heart is. Good to me. The heart is over on the right side of the body. So Mrs. Bartz goes like this. Did it move from my last lecture? And then this person had blood coming out of every place that you can think of all over the body. Blood goes to the uvula through the superior and inferior you know, and all over the place. I mean, they couldn't do this, you know, if their life depended on it. No blood flow. Know what the job of the right side of the heart is versus the left side of the heart. Okay? And when I say blood flow, I think you know what I mean. Yeah? Blood goes to the right atrium, through the superior and inferior, vena cava, that kind of good stuff. All right. We talked about a few, not a lot, but we talked about a few meds, you know, in cardiology. We talked about aspirin being an antiplatelet. Platelets are cell fragments. And what they do is they stick together, yeah, to try to stop bleeding. But the thing of it is, if they stick together, they could also form a what? A blood clot. And that's probably why we're here with this patient today, right? So, you know, what does the American Heart Association say? You know, you're home, somebody's having maybe a second or third heart attack. What does it say we should do with aspirin? And what kind of aspirin? And how much? Know about nitroglycerin. I'm going to talk to you guys about that before. Okay. How do you take it? How much? What's it for? If I say initial phase of ventricular repolarization, aka plateau phase, I mean, if I'd say something like that, yeah? Versus what? Rapid phase, okay? Know which leads are positive and know which leads are negative. Remember the first thing we saw in the book is something called Einthoven's triangle, yeah? And what was that? Lead 1, going from the right arm to the left arm, what? The right arm is negative, the left arm is what? Positive, okay? Lead 2, going down like this, yeah? From the right arm to the left foot. Lead 3, going from the left arm down like this, okay? Again, to the left foot, okay? Know what your lateral leads are. I mean, if I were to say lead 1, boy. Let's put it this way, my coffee is not kicking in. Know what your leads are, like laterally, okay? What are the lateral leads? What are the inferior leads? What are the anterior leads? Know those. Okay, we talked about the nervous system. I gave you a breakdown of it, all right? Remember this? Starting out with the central nervous system, okay, the brain and the spinal cord, the peripheral nervous system, 12 pairs of cranial nerves, 31 pairs of spinal nerves, yeah, okay? And then breaking it down from there, okay, into somatic and autonomic, yeah, and autonomic splitting off into sympathetic and parasympathetic. So if I were to say to you, the sympathetic nervous system kicks in, what kind of response cardiovascularly may I have? You know about the chemicals that are released with that. If I say acetylcholine, ACH, yeah? Is that sympathetic or parasympathetic? Or if I'd say norepinephrine, okay? Once again, sympathetic or parasympathetic? And what kind of reactions can you expect? Remember overdrive suppression? If I go back and I say, hey man, we're sitting, having a malt or some fries at one of the places in town, yeah. And all of a sudden my SA node just says, that's it, I'm checking out for a little bit. Are you dead? No, because you have 3 backups, right? What are those backups? In order. Okay, I mentioned to you 3 types, at least one book did this, 3 types of cardiac arrest. You know what those are? Okay. Once again, where do you place your leads? How do you find them? Now, one thing I was going to show you, don't run out of the room. Okay. Kids, this is X-rated. No, 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 no. All right, look. Up here you have a little notch. You get bored with my lectures, you can just stick your finger there. Little notch. It's at the top of the sternum. It's called the suprasternal notch. Right there. Okay. Now watch this. If you go down just about almost 2 fingers from that notch, right here, there's a horizontal shelf, little ridge, okay? And that ridge is called the angle of Louis. The angle of Louis. Now it looks like Lewis, but we pronounce it Louis. Okay, so here's the suprasternal notch. You go down about almost 2 fingers from there, okay? Right there, and it's going across like this. It's horizontal, yeah? And it's called the angle of Louis, okay? If you move over from the angle of Louis, you're going to hit the second rib. Okay? If you go down, if you just kind of feel the ribs and go down one more, you're going to hit the second intercostal space. So when you're putting on electrodes, guys, you have to feel where they go. You can't just look at somebody and go, and kind of shoot them up with these these little stickies and go, I hope that's right. You actually have to palpate. You have to feel. Remember, there's something called Gemini. I'm going to tell you right now, I'm not going to go any further with this, but Gemini. Gemini, not Gemini Cricket, but Gemini is a premature beat that couples or links itself, yeah, with normal beats. So I'll give you one example. If we had Bigemini, it'd be a premature beat linking itself with one normal beat. Or Trigemini, but you got to count everybody in the group. Okay? So, and it happens over and over again, okay, when we see it. It just doesn't happen once for it to be Gemini. Okay, so with Gemini, I could come up with bi, tri, or quad, right? But you got to look at that premature beat and go, is this atrial? Is this junctional? Or is this ventricular? Why? Atrial Bigemini, junctional Bigemini, ventricular Bigemini, yeah. You got a ruled strip of paper, right? Of course you do, okay? You got 5 little blocks like this, 5 little blocks like this, forming one big block, okay? On a horizontal axis, on an EKG strip, horizontal, just like this, what am I measuring? On a vertical axis, what am I measuring? How much is each little block wide, time-wise? How high are they? Okay. Height and depth-wise, vertically. Remember we told you so you got to do some things before you run the EKG? You have to what? Calibrate it? Yeah. Okay, so what do you do when you calibrate it? An EKG. What there's knobs and dials and things like that. What are you doing? Okay. I mean, if I were to say to you, look, on the EKG, I just noticed something that looks like a Lincoln top hat, like this. What is that? What's that for? Or be able to identify things, words, hypertrophy, be able to tell me what it means specifically. Remember this statement? As a positive wave moves toward a positive skin electrode, there is a positive upward deflection on the EKG. As a positive wave, positive charges coming out of the SA node, as a positive wave moves towards a positive skin electrode, there is a positive upward deflection on the EKG. If the positive wave moves away from a positive skin electrode, guess what? There's a negative deflection on the EKG. Okay, so if you were to, let's just say V1. Where is V1? Fourth intercostal space, right sternal border. How are the charges moving? Downward and to the left. What did I just say? Fourth intercostal space, right sternal border. Okay. Guess what? The charges aren't moving towards it. They're moving what? Away from it. So V1 would normally look what? Positive or negative? And the answer is negative. And remember, we got some miscellaneous stuff going on here. If I say you have a symmetrically inverted chiasm Thom wave, what's that mean? You have ST elevation and a significant Q. What does that mean? You have stemming. What does that mean? We talked about blood work in the hospital. And one of the blood work we mentioned is troponin. I want you to know if they draw troponin, why is troponin kind of the major thing in a blood work to draw? What does it represent? And we're talking about cardiac enzymes. CPK, LDH, SGLT, troponin. Those are cardiac enzymes. But one that really stands out there is troponin. Why? Why does it stand out? You know about artifact. We mentioned 3 types. AC artifact, somatic tremor, wandering baseline. Remember, almost all over the place now, guys, are defibrillators. You know, in airports, everything like that. And they're called what? AEDs, automated external defibrillators, right? How important is that defibrillator to get to that patient? And how quick? Now, there's something in there, but how effective is CPR just in and of itself? But if it's all I do is CPR, well, what chance do I have of saving the victim? Now, that doesn't mean I shouldn't do it. You should always give the victim the benefit of the doubt, but, you know, where does CPR stand in there? And how quickly must we get that AED on? What is cardiac output? What is stroke volume? You know about the pericardium. Okay, we mentioned layers, right? Fibrous pericardium, parietal pericardium, visceral pericardium. Yeah. Know about preload, know about afterload. Know about abbreviations. If I say AVF, what does that mean? Okay. AVR, AVL. Okay. If I say lead 1, AVL, V5, and V6. Guess what? We just talked about the lateral leads. What if I say V1 through V4? Well, a couple things. There are a couple of them on the right side, right? But a couple of them are also what? Anterior. Okay. V1 through V4 could be the anterior leads too. Know the electrical conduction system. Yeah, where does it start? SA node. Where does it end up? Down in the ventricle somewhere. Right? Know about some early people that kind of helped us put a footing on this kind of, firm, right? Know about well, we mentioned Einthoven. Yeah, okay. He was a big guy with EKGs. Know about bundle branches. And know about a bundle branch block. So if I had a right bundle branch block versus maybe a left bundle branch block, what leads would I look in for each? I mean, what leads represent the right bundle branch? And what leads represent the left bundle branch? And what would I see, like in the QRS, if that happened? On a block, right? How would I distinguish an old infarct from a new infarct? I mean, when I'm looking at the EKG, how can I go, this is old, well, this is new? All right, let's see. Sweetheart, can you do me a favor here? Okay, I want to know about ST segment depression. Give me at least one cause. ST segment elevation. Give me another cause. Yeah. Symmetrically inverted T waves. What if I said this are an asymmetrical inverted T wave? In a long down slope, but just a gradual up like this. Yeah. What would that be? I'm going to give you something real quick here. Let me see if I can do this so you can maybe understand it. The heart not only supplies the rest of the body with blood and oxygen, but it has to supply itself with blood and oxygen. And it does that through arteries that are over the top of it and wrap around the back of it. And those are called coronary arteries. Now, those coronary arteries arise from the aorta. Remember I told you this before, the heart doesn't get blood into the coronaries until it relaxes, and the word is diastole. So during diastole, through the coronary arteries, the heart gets perfusion or supply of blood. When you look at the coronaries, there's two main branches. There's the right coronary artery coming off the right side, also called RCA, and there's the left coronary artery called LCA. Except the left coronary artery bifurcates, it splits. It splits into the left anterior descending. What does descending mean? Going down. Okay. And it splits into the circumflex, which wraps around the side and the back of the heart. Okay, let me say that again. Two main coronaries. RCA, right coronary artery, and LCA, left coronary artery. The left coronary artery is just a short piece, you know, and the left coronary artery splits, it bifurcates. It splits into the LAD, left anterior descending, and it splits into the circumflex, which wraps around the side a little bit and in back, all right? Now this, who knows? I may come up with something. Okay, let's see here. Now, if I were to say to you RCA, the RCA, the right coronary artery, supplies major areas of the heart with blood and oxygen. Just looking to see, I want to make sure I give you everything here, at least to look at, study. All right, now just take this with a grain of salt. Okay, I'm not going too deep here. I'd have you put on flippers and a mask or something. Okay, but here's the idea. What if I talked about a lateral infarct? Remember, infarct is the same word as necrosis, which just means dead. Okay. All right, so I talked to you about a lateral infarct. That is probably due to the circumflex, okay, which wraps around the side, which comes off the left coronary artery, right, one of the branches, okay, and wraps around the side. What if I said an anterior infarct? Well, let's go back to what I just said. The left coronary artery divides into two branches, the circumflex and the LAD, left anterior descending. Hello, anterior, anterior. So if I said an anterior infarct, it'd probably be due to the LAD, left anterior descending, okay, which is one of the coronary arteries, right? Now the right coronary artery also supplies blood, and I want you to hear this. RCA, right coronary artery, provides blood to the SA node. Ooh, that's important, isn't it? That's the pacemaker. To the AV node and to the bundle of His. Okay? Now the right coronary artery also rolls around the back over to the left ventricle to supply it with blood and oxygen. We go just a couple of steps further here. In some people they talk about dominance, yeah? And so they may say, I think I have a way to word this here. They may say, well, the base of the left ventricle, okay? And you say, what supplies it? Is it the right or left coronary artery? And the answer is whichever one is dominant. Okay? That's the answer to that. Now, probably the only way you could really tell which one is dominant is by an angiogram. Angio is vessel. What vessels are we talking about? Coronary. Gram is a picture. So they kind of shoot dye in there, yeah, and they can, they can follow that and see which one is dominant. The RCA also supplies, remember I said the AV node. And the left anterior descending, one of the branches of the left coronary artery, also supplies, okay, the right bundle branch and the anterior division of the left bundle branch. Remember, you've got the right bundle branch and the left bundle branch, right? But the left bundle branch also bifurcates or divides. It divides into the anterior division and the posterior division. Let me say that again. You've got the right bundle branch, yeah, and the left bundle branch. But the left bundle branch divides into anterior and posterior. Sometimes they call those fascicles, okay? Okay, now I'm going to go back to something I mentioned last night on Zoom. Ready? Well, I'm going to put her fists out like this, pounding on the desk. Okay, here it is. Rhythm, rate, P waves. Rhythm, rate, P waves. Rhythm, rate, P waves. PR, QRS. Rhythm, rate, P waves. PR, QRS. Rhythm, rate, P waves. PR, QRS. Okay, you got the idea. Those are the 5 areas that you have to examine when you're examining a strip. And you just don't look a little bit, you go all the way across till it ends, okay? And then those 5 areas should tell you what you're looking at. Okay? And that is what you're going to tell the doctor. Doctor, I've got a 3rd degree block at a rate of 40. Ventricular rate of 40. I've got atrial fib, ventricular rate, irregular, but the ventricular rate is approximately, it's hard to tell. It's going to change minute to minute, okay, moment to moment. Okay. I've got a junctional rhythm at a rate of 60. After that, you can talk about ST depression, ST elevation, symmetrically inverted T's, biphasic P's, and that's another thing, biphasic P waves. Okay. What's called diphasic P waves, yeah. Little hint, hypertrophy. Yeah. Okay. So, guys, there you go. God bless. Study hard. And if you have any questions, call me. I'll be in a nuclear submarine off the coast of Africa, so I won't be able to talk now. I'll be available for you. Have a good one, guys. Have a nice afternoon.